Hi, everybody. Welcome to Chapter 45, Alterations of Musculoskeletal Functions. So Chapter 44 is Structure and Function. It's the normal musculoskeletal, learning the musculoskeletal system. That's certainly something that you can refer to, but I'm just going to start lecturing with alterations. And we'll go ahead and start out with musculoskeletal injuries. Talk about fractures, dislocations, and subluxation. Let's start with fractures in musculoskeletal injuries. So when we talk about a fracture, you know we're talking about a broken bone. And they're categorized in different classifications. So I'm going to go over the different classifications, and fractures are extremely common. It's said that every person will experience 2 broken bones in their lifetime. So that's a lot. And so just a couple things I want to talk about before I talk about classifications that I don't have on this slide. It's just kind of helpful to know. The common causes of fractures. Number 1 is falls. People fall. Whether it's from a high height or not. Trauma, motor vehicle accidents, those are high on the list. Just a direct blow, like just getting hit with a bat, getting hit with a ball, getting punched. Direct blows are also common causes of broken bones, and child abuse is also in the top causes. Bones that commonly break. Number 1 is clavicles. Clavicles are the most commonly broken bones. Next being the arm, the wrist, and the hip. So the biggest drivers of fractures are age and gender. So women have 2 times more fractures than men when they get past the age of 50. So this is not uncommon in an older population. It's not uncommon in children as well as the teen years, but it's something we see very commonly in older people over 50. So fractures can be closed, meaning that the skin is intact, or they can be open. And you may know this is a compound fracture or an open fracture. The skin's open. There's a wound there. The skin has been broken open, and there's a risk for infection with an open fracture. There's a partial fracture and a complete fracture. So you can see here the complete, right here, displaced fractures, a complete break of a bone, causing it to be separated in 2 or more pieces. And a partial fracture is an incomplete break of a bone, like these. These are partial fractures, they haven't completely broken like a complete. There's impacted, right here, an impacted fracture when the bones are driven together. They get pushed together, slammed together. There are spiral fractures when a break spirals around the bone. A spiral fracture is common in athletes, and these are very difficult fractures to try to treat. And you can kind of see why. It's kind of a helix form around the bone. A transverse fracture is when the break is in a straight line across the bone. You see right here, just a straight line, a transverse fracture. And an oblique fracture is when the break is diagonal across the bone. It's like a slanted type of a fracture of the bone shaft. You can kind of see how it slants. A comminuted fracture is when the bone fragments into several pieces. So there's an example right here, a comminuted fracture. and it's more than two pieces. You can see how this is almost like a shattered bone. This is a common fracture in older adults because the bones are brittle. Next, we have a green stick fracture, which is a fracture generally seen in a young, soft bone, children, in which the bone bends and breaks. But despite the name fracture, during the majority of the cases, the bone is broken and difficult to find in x-rays. Right here, a green stick fracture. The bone breaks incompletely like a twig breaks, again, common in children, because these are more flexible bones that contain more matrix. So it's almost like it bends and cracks, but it doesn't really break in half. Again, a green stick fracture, more common in kids, difficult to see them on x-rays. Some other ones, a compression fracture is when the bone is crushed, causing the bone to flatten in appearance. You can see right here the vertebral disc, and here's a compression fracture. So this fracture is wedged or squeezed together here on one side of the bone. It kind of compresses here and it's crushed and it gets flatter. So this piece of vertebrae is flatter than these other ones that don't have a compression fraction in it. An avulsion is when a fragment of bone is pulled off, often by a tendon or a ligament. So it's a complete separation of a tendon or a ligament from its bony attachment. So see how that tendon is attached to the bone and it's just completely pulled apart. Typically, these avulsion fractures result from abnormal stress on the tendon or on a ligament. And we see avulsion fractures commonly in athletes, especially like sprinters, fast runners. So cause of fractures, one, trauma. Like I said, fractures could be due to excessive trauma to bones. It could be auto accidents, falls, sports related. Osteoporosis is another cause. It refers to a group of bone diseases in which bone reabsorption outpaces bone deposits. So the bone becomes porous. And sometimes people with osteoporosis, they have what we call a pathological fracture, a fracture that occurs in a bone and they didn't even do anything. They didn't fall. They didn't have an accident. They didn't slip. They didn't have any type of trauma. They just got up out of bed and walked and got a pathological fracture. Overuse is another cause. Professional athletes put their bodies through high endurance training, and these oftentimes constitute a lot of stress on bones and joints. And these present typically as stress fractures, and a stress fracture generally is from overuse and reported force over time. So some physical exam features for fractures, just in general, pain on palpation over the fracture site. And these physical exam and presentations and clinical manifestations can vary depending on the type of the fracture, where the fracture is, the site, the arm or the leg. Is there a soft injury, a muscle or a tendon or a ligament that is also injured? So they can be different. Like you can look at physical exam features for all kind of different broken bones. These are just general clinical manifestations. So again, pain and tenderness when you palpate over the fracture site right here. Maybe they have a limb deformity meaning that it's not aligned. You see this deformity right here. It's misaligned. Palpable or audible crepitus, where you can kind of push on it and you can feel just the air that has gotten in there and it feels kind of like Rice Krispies. Maybe there is some absent or diminished distal pulses. So maybe if there's a fracture here in the arm, the radial pulse or the ulnar pulse is not palpable. Certainly swelling. You can see this arm is much more swollen. Any ecchymosis or frank bleeding that can manifest as bruising could be seen. Decreased or absent range of motion distal to the fracture. Basically mean they have impaired function. They aren't able to move it. Neurological injury distal to the fracture, maybe some impaired sensation, numbness. Maybe there's a nerve that gets pinched because of swelling, or even a nerve that may get severed. So there can be some neurological side effect or symptoms as well. Lab and diagnostics, radiologic evidence of fracture. So typically when we want to get an x-ray of somebody's arm or leg or something that we think that they have a fracture, we want to get two views. We want to get an AP, which is an anterior posterior view, and a lateral view. So we'll always get two views. If we have a big bone like this, for like a fracture of a humerus or a femur or ankle, we get oblique films. So just to kind of let you know, there's different films that need to be, we need to be used for diagnostics depending on where the break is. Leukocytosis in response to trauma, hemoglobin and hematocrit, so we can monitor blood loss from the fracture site. Urinalysis for somebody who has a crush injury to check for myoglobin, and we'll talk about that coming up. Electrolytes, especially potassium, as when somebody has a crushed injury and those cells the cells get crushed and smashed and they open up. Remember, the inside of this cell has a lot of potassium in it. So we want to be concerned about hyperkalemia when we have somebody who has a crush injury. Type and cross match. Mostly if a long bone or a pelvic bone is injured, a type and cross match in case they need to do a blood transfusion. Continuous EKG with a crush injury, again, just to monitor in case they become hyperkalemic. Arteriogram or Doppler ultrasound if diminished or absent distal pulses in that extremity. And management, splints, casts, braces. So manipulating and realigning the bone, which we call a reduction, is something that needs to be done to correct that anatomy or that anatomic position that is misaligned. Surgery is often used when there is need for alignment, and we can have a closed reduction or an open reduction. And reduction, again, is the realignment of the bone. And if it's a closed reduction, there's no invasive surgery. It's just aligned without opening or making an incision. And an open reduction is an invasive procedure that is used. An orthopedic surgeon does it, takes the person to surgery, makes a cut, and manipulates the bone through like an open area. So many broken bones can heal without a reduction or manipulation and require only immobilization. So splints, casts, braces are immobilization, but a reduction would be if somebody needed manipulation, and then they would also get, most likely, something that keeps them immobile, like a splint, cast, or break. All open fractures require antibiotics, opioids for pains, or other means of pain management. And certainly if it's an open fracture, we need to assess the need for a tetanus shot. So this is just kind of when we talk about antibiotics right here for open fractures. I don't want you to memorize this. I just want you to know a couple things about it. Basically that this table is just a classification of open fractures, okay? So they're graded 1, 2, 3, 3A, 3B, 3C, which you do not need to memorize, but just kind of get a big picture of this. Grade 1 is less than 1 centimeter. Grade 2 is a 1 to 10 centimeter laceration. Grade 3 is greater than 10 centimeter laceration, okay? So these grades are based on size. This is a little teeny laceration, medium, large laceration. And then this 3 is basically broken down into how much tissue is available to cover the wound. And here is there an arterial injury. So from mild to very severe. And if they're graded that way, and if they're open, they need an antibiotic. So how do we cover them? If it's just a very minor laceration, a grade 1 to 2, we cover for gram-positive bacteria, right? Basically, strep and staph, both of those live on our skin. That's where they live. And if we get a cut in our skin and that strep or staph gets inside of it where it's not supposed to be, and it gets into the bloodstream and travels around, gets into this tissue right here, they obviously could get an infection. So gram-positive coverage for a minor wound, because that covers strep and staph. And if it's a grade 3, they have to have a stronger antibiotic that covers gram-positive and gram-negative bacteria, because now we become concerned of Pseudomonas, and Pseudomonas is a gram-negative coverage. So for a more serious laceration, obviously there's more chance of a more virulent bacteria, gram-negative. You don't need to memorize these antibiotics, the cefazolin and the gentamicin. You'll learn that in pharmacology. You just understand mild, gram-positive, more severe. We want to do a stronger antibiotic. If MRSA is suspected, then generally they will be getting vancomycin. So complications of a fracture, a couple of things. Compartment syndrome is a painful and dangerous condition caused by pressure buildup from internal bleeding. Oops, where is it? Or swelling of the tissues. And what happens over here is they get this compartment starts getting filled up with blood and fluid from swelling, and it compromises the circulation and the function. And as it compromises it, it compresses on the artery, and they have no circulation down here in the bottom of their foot. And the body has 46 compartments, and 38 of them are in the arms and legs. So most typically compartment syndrome occurs in bones and legs. Now it also can occur in the belly, but most commonly in the 4 extremities. And certainly can be serious, not just because it's painful, but because it's occluding the arterial circulation to the foot. So fasciotomy often has to be performed where they cut this open and they release some of the pressure in there. Fat embolism is another complication. It's a disruption to blood supply caused by fat globules in a blood vessel, most commonly associated with orthopedic traumas. That's generally when we see fat embolism. And you can see this over here. Fat embolism syndrome can happen within 2 to 3 days after a major bone break or other types of trauma, generally a big bone break like a leg. Okay, so what happens is when they have this big break, okay, they have this big break in the bone, like this femur, and it breaks. Somehow fat from the system gets into the bone and it gets into the circulation, and the fat travels around just like an air embolism would, but it's a little teeny fat globule. And when it starts to lodge in places, the symptoms that come with fat embolism syndrome are trouble breathing, so respiratory distress. They start becoming a little distressed in their breathing. Certainly that would lead to a tachycardia. But here's a main one right here, because it can lodge in the lung. Here's another main symptom right here. They have mental state changes, so they have altered mental state, or they may have some confusion, and their level of consciousness is just starting to change. So their mentation is different. They could have vision changes, liver changes. they tend to have fevers, okay? They tend to have fevers when they have this fat embolism. And something even more specific, try not to forget, because this is often one of the a love for standardized test questions when they're talking about fat embolism, which is not common. It's not something that's common, but it's certainly something that should be picked up when it happens. But they get a little petechiae rash, like a little bit of the capillaries kind of burst open, and they get petechiae rash generally on the upper trunk of their body. Okay, so those are some main 4 symptoms that go along with fat embolism. The next one is osteomyelitis, inflammation of the bone caused by an infection, generally in the legs, arms, or spine. Somehow that infection can get inside the bone, typically from a wound on the outside, and it travels and gets in the bone. So this is a bone infection, which is actually in this PowerPoint kind of at the end. We'll talk a little bit more about. And then the last one, osteonecrosis, is a death of bone tissue due to a lack of blood supply, which can be caused often by osteomyelitis right here. And you can see osteonecrosis right here, where this is just dead bone. It just never got, it just went through a time period where it did not get any oxygenated blood to it. Okay, the next thing we'll talk about are dislocations and subluxations. So when we talk about a dislocation right over here is both caused by trauma, an injury where a joint is forced out of normal position. So basically a complete loss of articulation of the bone ends right here within the joint capsule. So here's a normal anatomy of the shoulder. Here's a dislocation anterior and a dislocation posterior, anterior and posterior just meeting the position that it's moving, but you see how it is just a complete loss of this articulation. This is not partially out of the joint, it's completely an injury where the joint is forced out of normal position. Whereas a subluxation is a partial dislocation. So again, here's the normal shoulder and here's a subluxation. It's not a complete dislocation, it's just a little partial dislocation called a subluxation. Complete loss of articulation of bone ends within the joint capsule. Etiology, blunt trauma. It could be congenital. Some people get them and they just get them all the time. You can kind of see here the little bit of joint deformity that this kid has right here. But there's some people who just go to the ER frequently because they have these congenital dislocations of often a joint, often their shoulder. Inflammatory diseases can cause it, seen in all age groups, but it's more common in, your book says less than 35 years old, but even more uncommon, or excuse me, more common in less than 20. So this we typically see in a younger age group who are participating in sports and have maybe experienced some trauma. They're very commonly associated with fracture. So somebody can have a fracture and a dislocation together. Subjective and physical exam findings, pain over the affected area, obvious joint deformity like this guy right here, and just symptoms are very similar to fractures like pain and swelling and immobility and tenderness, just the same things. So typically these dislocations and subluxations occur most oftenly in joints of the shoulder or the elbow or the wrist or the finger or the hip or the knee, but shoulder's number one. So lab and diagnostics, definitely an x-ray. An x-ray is how it can be diagnosed. And we want to draw blood counts again because we want to make sure that there's not some internal bleeding and somebody's H&H is going down. Management, early anatomic reduction is essential. So this has to be reduced. It has to be moved. It's got to be put back in place. And then they are immobilized. Generally, once this gets reduced and put back in place, this gets moved back to where it's supposed to be here or here, then generally they get a immobilization for about 2 to 6 weeks, so maybe like a sling or something like that. And they would, if they needed like an open reduction, they would have to have surgery. Okay, That's it for part 1. And I'll see you for part 2. Thank you.